Welcome to the conference session titled Aplastic Anemia, Non-Transplant Therapies. Thank you for joining us today. My name is Ankirika Ashadu. I'm the Program Content Manager at MBBS, and I will be moderating the presentation today. As we get started, we want to recognize the generosity of our corporate sponsors, patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We'll do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. Submit your entire question at the same time, and please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Srinivas Tantravahi. Dr. Tantravahi has received his medical degree from Guntur Medical College in India. He then completed his internal medicine residency and hematology and oncology fellowship training at the University of Utah School of Medicine. He is currently an assistant professor in the Division of Hematology and Hematologic Malignancies at Huntsman Cancer Hospital at the University of Utah. His clinical interests include chronic myeloid leukemia, myeloproliferative neoplasms, aplastic anemia, and inherited bone marrow failure syndromes. He is a member of the American Society of Hematology and the American Society of Clinical Oncology. His work is published in reputable journals including Cancer Cell, Leukemia, and Blood Advances, and has presented his work at national and international meetings. With that said, welcome Dr. Tantravahi.
Thank you. All right, welcome back. My topic today is to go over the non-transplant therapies for aplastic anemia. Let's see. There you go. Here are my disclosures. So what I would like to cover today is to go over some fundamentals of aplastic anemia and how we distinguish the autoimmune aplastic anemia from inherited bone marrow failure syndromes. The talk that was given earlier by Dr. Agarwal makes my job easier to go over some of these distinctions. And then I'll briefly go over the comprehensive pediatric and adult bone marrow failure program that we set up a few years ago at the Huntsman Cancer Hospital and University of Utah. In that, I will go over our initial diagnostic approach when we encounter a patient with bone marrow failure, how we distinguish acquired immune-mediated aplastic anemia from inherited bone marrow failure syndrome, and then how we pick treatment based on the certain characteristics such as age and donor availability. Then I'll also go over some of the treatment options for relapsed refractory aplastic anemia. And finally, I conclude with a couple of case studies on our own patients that are treated here. Aplastic anemia is a bone marrow failure disorder, but it has a very distinct pathophysiology of how the disease occurs. So it is an autoimmune disease characterized by an immune attack on the bone marrow stem cells. In principle, the stem cells in patients with aplastic anemia are otherwise healthy. They're able to divide and able to produce and maintain blood cell production. But because there is an immune attack on the bone marrow, it severely compromises the ability of these stem cells to maintain adequate amount of blood cell production. And therefore, it's a clear a different pathophysiology compared to other conditions such as MDS and inherited bone marrow failure syndromes. It is a rare disease. The incidence is only estimated to be approximately about 2 cases per million persons per year. And it occurs sort of in two distinct peaks in terms of age. There are young patients who are typically in 15 to 20 years of age, there is a peak, and then there is a second peak that occurs between 65 to 69 years of age. So as I alluded, because there is an immune attack on the bone marrow, the stem cells can no longer sustain the production of blood cells. So these patients present with, here it's a blood film under the microscope where there is too much space between the red cells. That means that there's anemia, and you're also not seeing any white blood cells and platelets other than a single lymphocytes. So there is significant compromise in the production of blood cells, including red cells, white cells, and platelets. Therefore, the symptoms at presentation are often related to these severely compromised blood cell production. And when we look at the bone marrow, a normal healthy adult bone marrow should include some fat cells and also a blood cell producing cells. But in aplastic anemia bone marrow, all we see is these sort of air pockets, which are essentially these adipocytes or fat cells that the marrow is completely replaced by, indicating that there is severely compromised blood cell production here. And because it affects more than one type of blood cells, we often need, in order to make a diagnosis of aplastic anemia, to have a compromised red cell, platelets, and neutrophil production. So the criteria here is that the hemoglobin is less than 10 grams per deciliter, platelet count of less than 50,000, and absolute neutrophil count of less than 1,500, and we need at least 2 of the 3 criteria in order to make a diagnosis of aplastic anemia. It's kind of challenging to advance these slides. Maybe I should do it here. Yeah, there you go. So once we make a diagnosis of aplastic anemia, we have to then determine the severity of aplastic anemia. So what that means is that there are some patients with aplastic anemia who meet the criteria of the disease, but the blood cell production is not severely compromised. And we call that as non-severe aplastic anemia. But the severe form of aplastic anemia is where you have an absolute neutrophil count of less than 500 and the platelet count of less than 20,000. And the other criteria is this so-called reticulocyte, which is essentially the sort of a little bit more immature form of red cell, and often a surrogate marker on the amount of blood cell production from the bone marrow, and that is less than 60. So there are a group of patients that present with so-called very severe aplastic anemia, and these patients have, in addition to the criteria for severe aplastic anemia, they have severely compromised neutrophils, the infection-fighting white blood cells, which is less than 200. And then, as I said, the non-severe aplastic anemia is where the criteria is met, but the blood cell production is not severely compromised. So aplastic anemia is a diagnosis of exclusion. Like we had, like Dr. Agarwal has talked about earlier, that one of the key distinctions when you encounter a patient with aplastic anemia is to rule out the possibility of inherited bone marrow failure syndromes. And then there's also a little bit of a spectrum between aplastic anemia and where the stem cells are healthy and the disease is caused by an immune attack in the bone marrow. It should be distinguished from myelodysplastic syndromes where the stem cells have mutations, like the seed, soil, and the garden analogy that Dr. Agarwal gave earlier. And these patients should be distinguished from the immune-mediated aplastic anemia because the treatment is different. And there's also some overlap with PNH, where there can be a small PNH clone in patients with aplastic anemia. So we'll go over a little bit of those in the next 10 minutes. So among the inherited bone marrow failure syndromes, there are two groups of disorders that account for sort of the majority of these conditions. One is Fanconi anemia, the other one is a telomere biology disorder. So in Fanconi anemia, there is a defect in the DNA repair pathway. Therefore, there is an increased risk of developing not only a bone marrow failure syndrome, but also sometimes these MDS and acute myeloid leukemia. And the second group of disorders are telomere biology disorders that need to be identified when you encounter a patient with aplastic anemia, so that we tailor the treatment approach differently. What makes it a little challenging is that, as we talked about earlier, that in about 20 to 30% of the patients with these syndromic disorders, such as Fanconi anemia and telomere biology disorders, they are indistinguishable from patients with aplastic anemia. That means that they do not have any typical phenotypic features like skeletal abnormalities or other skin findings to help us to distinguish. Therefore, it is really important to have this high index of suspicion, particularly in young patients, to rule out the possibility of inherited bone marrow failure syndromes. And when it comes to PNH and aplastic anemia, it turns out that about half of the patients with aplastic anemia have a detectable small PNH clone. And what we think is that this represents is actually an immune attack in the bone marrow. We think that the PNH clone develops as kind of a response to the immune attack in the bone marrow, and the PNH cells have the ability to escape the this immune attack. Therefore, detecting a small clone of PNH cells in somebody that presents with aplastic anemia helps us to determine that this is actually an autoimmune disease. Although it's not always 100%, but it decreases the possibility of an inherited cause for the bone marrow failure. So essentially, these PNH clone or these stem cells that survive immune attack and expand over time. And the other thing is that because it is sort of a surrogate marker for an autoimmune attack, these patients who with aplastic anemia that have a PNH clone have a high probability of response to immunosuppressive therapy that we often use to treat aplastic anemia. So how do we detect this PNH clone? We use this test called flow cytometry. And the flow cytometry allows us to detect these very small clone of PNH cells and also helps us to distinguish from the clinical form of PNH. Here, in this cartoon here, these are these red cells that are normal, whereas in subclinical PNH, there are a small group of red cells that actually don't express these so-called CD55 and 59, and they represent basically the PNH clone. And there are some patients where there is an overlap of both PNH and bone marrow failure. Here, the PNH clone is a little bit higher than in individuals with subclinical PNH. And the bottom part represents basically PMNs, which are neutrophils that don't have that belong to the PNH clone. Let's see. So one of the key aspects of treating aplastic anemia is to differentiate from inherited bone marrow failure syndromes, because the key treatment principle of treating inherited bone marrow failure syndrome is using a stem cell transplant to cure this disease, even though there are some patients that may respond to medical therapy, but these are the patients that you want to treat with a transplant. Whereas in autoimmune aplastic anemia, the treatment decision between medical therapy and transplant depends on the age of the patient and also based on the availability of the donor. The second reason to distinguish is that we have to tailor this so-called conditioning chemotherapy that we give before the transplant in patients with certain inherited bone marrow failure syndromes, particularly Fanconi anemia. So therefore, there needs to be a high index of suspicion and to rule out these inherited bone marrow failure syndromes in patients that are presenting with aplastic anemia, particularly young individuals. The other important reason is that it also allows us to make some informed decisions to select a donor, whether you want to use a family donor, most often a sibling donor, or an unrelated donor. So in the setting of an inherited bone marrow failure syndromes, and if a sibling donor is used, it's super important to make sure that there is no inherited cause which can eventually cause disease relapse if you transplant from the sibling who has the same mutation that actually indeed led to the development of bone marrow failure in the patient. And then it's also important to screen unaffected family members that we talked about earlier, that the same mutation can manifest in many different ways in two different family members. So the family member may have the mutation, but the disease is not manifested yet, and identifying that will allow us to screen and intervene before the disease is too advanced. And then obviously the genetic counseling and family planning also an important reason why we have to distinguish aplastic anemia from inherited bone marrow failure syndromes. So when we started treating patients with bone marrow failure at our institute, we recognized this, that we need a more sophisticated program where we have experts in different areas, both in adult and pediatrics, to adequately work up these patients and come up with a multidisciplinary approach in terms of treatment planning. So we developed this program, and we also collaborated with another leukemia and transplant program in the Valley that is operated at the Intermountain Medical Center, LDS Hospital at the Intermountain Healthcare. So the other key aspect of it that is needed for a bone marrow failure program is a good genetic counselor. So we're lucky to have Jenny Weger, who works and helps in facilitating the genetic testing and also screening the unaffected family members, and also a key component of sort of identifying the family donor if we have to do a transplant. And what we created is that we meet every 2 weeks and we talk about every patient, and so that we have a multidisciplinary approach, both in terms of diagnostic workup and also coming up with a treatment plan. And the long-term sort of goal of the program is also to continue education efforts and also sort of advance our learning about these bone marrow failure disorders by conducting research. So how do we work up a patient with a suspected aplastic anemia? We do blood counts. As I talked about earlier, we try to identify whether these patients have a PNH clone or not. So we have a world-class lab at the ARUP laboratory, which is affiliated to the University of Utah, where we perform this high-resolution flow cytometry that allows us to identify these subclinical PNH clones. And then we also do something called SNP array, which is basically sort of allows us to look at the whole genome of the blood cells, and to look for certain changes in chromosomes, particularly this so-called 6p-LOH, which is also seen in the setting of an immune attack in the bone marrow, and rarely seen in inherited bone marrow failure syndromes. And then a bone marrow biopsy is also a critical component to diagnose aplastic anemia. Then if there is a PNH clone or a clone of 6p-LOH, we feel more confident in ruling out inherited bone marrow failure syndromes and calling it as an autoimmune aplastic anemia. And it is not 100%, but if there is still a suspicion that a possibility of inherited bone marrow failure syndrome based on family history or certain clinical features, then we would still consider a genetic workup. But identifying a PNH clone or a clone of 6PLOH will really sort of differentiate, help us to minimize, genetic testing in everybody. And then if there is no PNH clone or a 6PLOH, then we do two important tests to sort of rule out the possibility of inherited bone marrow failure syndromes. The first one is so-called chromosome breakage analysis. Dr. Agarwal talked about this earlier, that in patients with Fanconi anemia, the cells are susceptible to DNA damaging agents. So what we can do is we can actually take cells from the patient, grow them in the lab in the presence of a DNA damaging agent called diepoxybutane, and then we can look at cells under the microscope to see how susceptible they are to this DNA damaging agent. So if we see lots of different abnormalities in the chromosomes, then it is considered positive, and it indicates that these patients may have a genetic disorder, a genetic mutation that caused Fanconi anemia. And if it comes back positive, we do a sequencing test that includes all the genes that are implicated in Fanconi anemia. And the second test that we do is this measuring telomeres. We talked about earlier that these telomeres are present at the end of the chromosomes, and they protect the integrity of the chromosomes. And in patients with telomere biology disorders, because of their mutation that they're born with, there is accelerated telomere attrition, and that therefore there is stem cell exhaustion and increased risk of bone marrow failure. And we can actually measure the length of the telomeres by sending this, by analyzing the length of the telomeres by using this assay called flowfish. And if there are short telomeres, then we do sequence for the specific set of genes that are implicated in telomere biology disorder panel. If both tests come back negative, and if we still have the suspicion for inherited bone marrow failure syndrome, then we consider doing this broad panel that includes a number of genes that are implicated in causing bone marrow failure. So by using this sort of approach, doing this functional analysis allows us to do more tailored genetic testing and then reserve more comprehensive genetic testing for patients that we don't see these, the results are negative for either chromosome breakage or flowfish. So once you make that distinction and diagnose this autoimmune immune-mediated aplastic anemia, you have two different options in terms of treatment. To keep it simple, there is medical therapy and there is bone marrow transplant. So medical therapy can be very effective because it's an immune-mediated disease. What we can do is we can give treatment to suppress the immune system so that we allow the bone marrow to restart blood production again, and therefore improve the blood counts. So the main advantage of medical therapy is that the complications of medical therapy are quite minimal. And it can be quite effective in almost 2/3 of the patient in sort of resetting blood cell production and improve the blood counts to the point that they no longer require transfusions and they have adequate amount of blood cells. The downside of medical therapy is it's not curative. So many patients who initially respond to medical therapy may relapse again. And then the other downside of medical therapy is that we talked about earlier that there is there's a little bit of a spectrum between aplastic anemia and MDS. What that means is that some patients with aplastic anemia may have low-level mutations in the same genes that are also mutated in MDS patients. So therefore, there is this risk of clonal evolution to myelodysplastic syndrome, and we can't get rid of that with medical therapy. Whereas bone marrow transplant, it's a curative treatment, and you basically replace the patient's bone marrow with a healthy bone marrow from a donor, And so you can have normal blood cell production, and you also have a new immune system. Therefore, you get rid of this autoimmune process that's going on in the patients. What are the downsides? There are, we're recognizing that increasing rates of graft failure. That means that when we do the transplant, the patient bone marrow doesn't adequately take up the donor stem cells. Therefore, you don't have a blood cell production. And then the main dreaded complication for bone marrow transplant is this so-called graft versus host disease, which can be acute. That means it can happen quite early in the course of transplant, or it can happen later. So basically, sometimes these patients can develop another chronic illness in the form of chronic GVHD, and it's always challenging to treat those. However, we've gotten better in terms of getting smarter with the bone marrow transplant procedure, where we are doing interventions to decrease the chance of developing both acute and chronic GVHD, and also decrease the risk of other transplant-related complications. So bone marrow transplant is a very good and effective treatment for aplastic anemia. So how do we approach in our program when we treat patients with severe aplastic anemia? So the first thing is we look for a matched sibling. So we do the typing for the patient and all their siblings, and not start any treatment, but in turn instead give supportive care with transfusions and antibiotics as needed. And if they're young, which the cutoff is 40 years of age, which sometimes can be sort of arbitrary, so it needs some individual approach. But in principle, if they're young and age less than 40, and they have a sibling that is fully matched, our approach is to move forward with sibling donor transplant without doing any medical therapy, and instead just provide supportive care until we get ready for a sibling donor. And typically, if we do the workup as quickly as possible as patients walk into our door, we can actually perform a sibling donor transplant in about 8 weeks of time, or sometimes even less. So the quickest we were able to move forward to a sibling donor transplant since I've been here is about 6 weeks. But that requires sort of immediate workup and look for the match. If they are over 40, even in the presence of a matched sibling donor, the current recommendations are to consider this immunosuppressive therapy. So the treatment of choice is this ATG, which is basically suppresses these active sort of T lymphocytes that are attacking the bone marrow, and then an oral medication called cyclosporin, and then we incorporate this drug called eltrombopag into the treatment. Here, what eltrombopag does is, it doesn't suppress the immune system, but instead stimulates the bone marrow. So essentially, you suppress the immune attack by using ATG and cyclosporin, and the eltrombopag essentially sort of wakes up the bone marrow to start blood cell production. So if the patient is over 40, even in the presence of a sibling donor, we would consider have a high threshold to use treatment with ATG, cyclosporin, and eltrombopag. And if we see a good response, then we keep track of these patients over time. Or if there is no response or relapse, then we move forward to a sibling donor transplant. And if there is no sibling donor transplant in the event of relapse, then we could consider an unrelated donor transplant. And the next approach on the other side is when there is no sibling donor transplant. If there is no sibling donor in really young individuals, particularly under 20 years of age, there is still some benefit in moving forward to an unrelated donor transplant from the registry. Or sometimes even consider a haploidentical transplant with careful considerations. So these group of sort of young adults or children, young adults where age more than 20, but they don't have a sibling donor, then we would still consider horse ATG cyclosporin and use transplant in the setting of relapse or no response to this medical treatment. What are the chances of response to this medical treatment? So this was a study done by the NIH where they gave two different types of ATG, horse ATG versus rabbit ATG, and it is given in the hospital for 4 days as an infusion, followed by treatment with this oral medication called cyclosporin. And what we've found out in this study is that horse ATG is superior to rabbit ATG in recovery of blood counts, in promoting the recovery of blood counts at 3 months and at 6 months. So if you see here, approximately 40% of the patients had recovery of the blood counts at 6 months with horse ATG compared to rabbit ATG. And in this protocol, so we typically use this cyclosporin for about 6 to 12 months, and then gradually taper over the next 18 to 24 months. And subsequently, as I alluded earlier, that adding L-Trombopag to the horse ATG and cyclosporin treatment improves the chances of recovery of blood cell production. So this is a sort of a randomized study that was conducted recently and published by the European group, where they gave patients with autoimmune aplastic anemia horse ATG and cyclosporin in one group, the group A, and the group B got ATG, cyclosporin, and L-Trombopag. And when they looked at the rates of complete response at 3 months, adding L-Trombopag almost doubles the chance of complete response at 3 months. And when you look at the response at 6 months, group B, where these patients received L-Trombopag in addition to horse ATG and cyclosporin, the complete or partial response at 6 months is about 70%. And also the time to recovery of the blood counts is way faster, 3 months compared to 8 months when you add L-Trombopag to ATG cyclosporin. Therefore, this basically sets a new precedence that when you select, once the medical therapy is selected for patients with aplastic anemia, we incorporate L-Trombopag early in the course of the treatment so that they have increased chance of recovery of blood cells production. And in terms of doing medical therapy for relapse aplastic anemia, there are the number of options. Instead of going over through each option, I thought we can sort of split it into two separate groups. One is high intensity, which is basically we treat a little bit more aggressively. These are young patients that can tolerate more intense treatment. And the low intensity is basically for older patients where you give treatment that's less likely to cause infections and other side effects. It turns out that if there is relapse of aplastic anemia after an initial response, we can retreat some of these patients with the same treatment that they have received before. So that means that we can use a horse ATG with cyclosporin, and if they haven't received L-Trombopag in the first place, then you can add L-Trombopag at the time of relapse. Or you can switch from horse to rabbit ATG if there is no response to horse ATG, or the disease come back way too early. And then there are also other sort of so-called immunosuppressive therapies that are similar to cyclosporin. And these drugs basically are combined with either with ATG and under L-Trombopag. So for example, we often use this drug called tacrolimus, and there are other immunosuppressive agents similar to that drug. And then there's another drug called alemtuzumab, which is also another option that we can use to treat relapse. And finally, these androgens, there's a medication called danazol, which sometimes can be quite effective, and we don't know exactly how it works, but somehow it sort of allows these stem cells to sort of survive the immune attack and start producing blood cells again. So on the low intensity arm, again, these immunosuppressive medications such as cyclosporin or tacrolimus or use androgens that even as a single agent to sort of restart the blood cell production again. And we have some luck using eltrombopag alone as a single agent in some patients at the time of relapse, and this drug is very well tolerated and causes minimal side effects. I want to kind of give a couple of patient examples to just sort of illustrate how medical therapy can be quite effective. This is a 74-year-old woman that came to my clinic, I think in late 2020 or 2021. So she actually presented to her primary care in a different state with fatigue and decreased exercise tolerance in late 2020. And at the time, she was anemic with a hemoglobin of 9, and the platelet count was low, 33,000, and also neutropenic, but not severe. And a bone marrow biopsy was performed, and a diagnosis of aplastic anemia was established. She was seen by a hematologist and who recommended a treatment with eltrombopag, and she was subsequently lost to follow-up. And over the next few months, this woman got more and more sicker and decided to move to Utah to stay close with family. And actually, a couple of weeks after moving to Utah, she presented to ER after collapsing at home. And when she came to the ER, her hemoglobin was 4.8, which is sort of severely compromised. Platelet count was also really low, and her neutrophil count was relatively higher than the other blood counts. And we demonstrated that she had a small PNH clone by doing the high-resolution flow. So here, the graphs that I have here, these are the red blood cell count or hemoglobin concentration, and then this is the platelet count. So I couldn't convince her to admit to the hospital and do an ATG. She was terrified to do ATG. So we decided that we'll just try oral therapy first by using cyclosporin and eltrombopag. And you can see these peaks, ups and downs, are due to red cell transfusions. So there was no response after about after about 6 months on cyclosporin and eltrombopag, and then finally we managed to convince her to treat with ATG. So she received ATG in October of 2021, and over the next few months, starting about 3 to 4 months after ATG treatment, there's nice recovery of hemoglobin, and then and you can see in 2023 this has been maintained, and to date this patient is free of transfusions and doing well. And similarly with the platelet count, after addition of HOTS ATG, there is a gradual recovery of platelet count, and it almost kind of normalized over time, and the patient continues to be on low-dose cyclosporin and eltrombopag and maintaining adequate amount of blood cell production. So this kind of illustrates that in individuals such as this patient, where transplant is not an option because of our age and frailty, the medical treatment can be quite effective in restoring the normal blood cell production, and these patients can remain healthy without needing transfusions. The next case that I want to illustrate is to talk about sometimes patients with non-severe aplastic anemia may also need treatment even though they don't meet criteria. So this is it's very sensitive to touch. It's a 69-year-old gentleman presented in 2020 So I choose these patients that were treated a couple of years ago that I have some follow-up data to show. And he presented with severe anemia and thrombocytopenia. The hemoglobin was 7.5, platelets were 15. He was requiring transfusions. When we first saw him, he came to my office in a wheelchair. So I was worried about giving him ATG. So we elected to do sort of low-intensity treatment that I was talking about earlier with just cyclosporin, an oral medication, and L-Trombopag. So we started that in September of 2020, and this is his hemoglobin concentration here. So he kept requiring transfusions, and then I noticed, some improvement in hemoglobin, and then the hemoglobin decreased again, and he started to sort of require transfusions over here sometime in 2022. At the time, we checked his erythropoietin level and found that his EPO was actually really low. So this was the reason so you need erythropoietin in order to produce red blood cells. And some of these older adults with other comorbidities, if there is not adequate erythropoietin, even if you stop the immune attack, they're not going to be able to produce red cells. So what we did was they added erythropoietin with darbepoietin shots, and you can see marked improvement in hemoglobin. And at the last follow-up, his hemoglobin is within the normal limits. I'm so sorry. Again, with the platelet count, you can see that the improvement in platelet count over time with just cyclosporin and L-Trombopag, that the platelet count, got to normal levels, and this is maintained to date. So this case, again, illustrates that two things. One is some patients with non-severe aplastic anemia may require treatment, and medical therapy can be quite effective, and because these patients technically don't qualify for transplant. And just treating with cyclosporin and L-Trombopag alone can really restore normal blood cell production, and it can be quite sustained for a period of time. So thank you for allowing me to talk. And I'm happy to take any questions and happy to answer any questions. You can reach out to me on my email. We have about 15 minutes.
Dr. Tantravahi. Now we'll take some questions from online and also from our audience. So I'm going to start with the online questions. So our first question is, I understand that there are no research studies on a protocol for weaning L-Trombopag and cyclosporin other than it's a slow wean. What is your regimen to wean from these drugs? What is the dose reduction for each drug over what period of time?
Thank you. That's a great question. So first, I'll talk about L-Trombopag. So in that European study where they randomized patients to just immunosuppression versus immunosuppression with L-Trombopag, if patients achieved a complete response, what I mean by that is the blood counts are almost within the normal range, and they stop the L-Trombopag after 3 months, even if they had a complete response at 3 months. If there is no complete response at 3 months, they evaluate again at 6 months and stop the L-Trombopag at the time. But some of those patients, when you stop L-Trombopag, have relapsed, and they add it back again at the time of relapse. So it is our approach that, especially for patients, even though if they had a good response but the blood counts are not quite normal, there is very little downside in continuing with L-Trombopag. There are some concerns that actually L-Trombopag promotes sort of this so-called clonal evolution and can lead to development of MDS down the line, but we don't have any sort of concrete evidence for that. So particularly for sort of older, frailer patients, my approach is to lean towards continuing it, because dealing with the relapse is much more difficult than continuing with L-Trombopag treatment. When it comes to the cyclosporin, the initial studies, people did stop cold turkey cyclosporin after 6 months or a year. And many of these patients sort of relapse down the later if you stop cold turkey. So what we sort of been doing is that we follow this approach where cyclosporin is weaned off gradually over about 18 months. So we decrease the dose of cyclosporin after achieving a good response by about 25% every 3 months. And so that'll result in about complete stop after about 18 months of treatment. But then after that, there is a sort of individualization in terms of their blood counts and all, because in my experience, when I stop cyclosporin completely, even after many years of excellent recovery of blood counts, we do still see late relapses. So that's where keeping some patients on low-dose cyclosporin is probably a good idea because to minimize the risk of relapse.
Okay, thank you, Dr. Tantravahi. Our second question, online question, is have non-transplant therapies been used successfully to restore all blood counts for very severe aplastic anemia? Is there a difference in non-transplant therapy outcomes based on whether bone marrow failure is inherited or acquired?
Yeah, so first part of the question is what are the chances of success of if you give medical therapy in patients with very severe aplastic anemia. So there is some data to suggest that patients with very severe aplastic anemia, or they have super low reticulocyte count at the time of diagnosis, the chance of response to this medical therapy are less compared to somebody who have a higher reticulocyte count. So if someone is a transplant eligible and they have a suitable donor, it is reasonable to consider a transplant early in the course in patients who are presenting with very severe aplastic anemia, or if they've already have some complications from the disease. So we're more likely to sort of recommend a transplant in patients with very severe aplastic anemia. The second thing is inherited bone marrow failure syndromes and the chance of response to medical therapy. Well, there are some patients, particularly with telomere biology disorders, that may respond to medical therapy, but they're more likely to relapse down the line, and that's why it's sort of critical to identify these patients with inherited bone marrow failure syndrome early, so we can kind of tailor the treatment approach and make informed decisions in terms of a transplant.
Okay. Our third question, or online question, is what do research studies cite as the number of years people with severe aplastic anemia who receive ATG, cyclosporine, and Eltramapag stay in remission?
Yeah, so the studies, we started incorporating Eltramapag probably in the last kind of 10 years or so, but the randomized study that was done was fairly recent. So the follow-up we have in these patients is sort of limited, but in principle, about half of the patients that are treated with medical therapy at some point do relapse. How long these other half of the patients that don't relapse actually stay in remission when you add Eltramapag, it's not known yet, but I think the results look really promising, even with sort of the short follow-up, about 2 to 3 years. And so far, there's no signal to suggest that adding Eltramapag actually increases the risk of clonal evolution to MDS or AML. But again, it's also short follow-up, and we kind of need to follow these patients for a longer period of time to see if there is increased risk of clonal evolution when you add Eltramapag.
Thank you, Dr. Tantravahi. So I wanted to just see if we have any questions in the audience. at all. So does anybody have any questions before I continue more online questions? Okay, so I'm going to continue some online questions. Another question that we got in was, I am in the process of being diagnosed with aplastic anemia, but my doctor is not sure. They talked about ITP as well. Are they two similar, and if so, how? Can aplastic anemia be misdiagnosed as ITP?
Yeah, that's a great question. So ITP is also an autoimmune disease. It is also a diagnosis of exclusion like aplastic anemia. But the key distinction is that in ITP, the attack is not in the bone marrow. So the patients with ITP actually have antibodies that bind to the platelets and clear them ways faster than patients without ITP. So what that means is that you should have otherwise normal red cell count and neutrophil count. So it is, the typical patient with ITP is somebody who presents with isolated. That means that the only abnormality in the blood counts is low platelets, and it's often severe, sometimes even less than 20 in an acute setting. Whereas aplastic anemia, it is also an autoimmune disease, but the attack is in the bone marrow. So you have compromised white blood cell, red cell, and platelet production. So that means that not only you have low platelets, you also have low red cells and low white cells. Where it gets a little tricky is that not all patients with aplastic anemia can present with severely compromised levels of all blood cells. So the distinction can be, fairly straightforward, but not always, because patients with ITP, particularly older individuals, they may have anemia for other reasons, but not aplastic anemia. So in those situations, careful evaluation of the bone marrow would help to make that distinction. Because as I talked about earlier, in aplastic anemia, when we look in the bone marrow, the marrow is replaced by fat cells, and you have less amount of blood producing cells. So a bone marrow can be helpful in that situation to distinguish, but for most part, we can distinguish even just based on the blood counts. So it's really important to make that distinction, because treating patients with aplastic anemia with prolonged course of steroids like we do in ITP is not going to be successful, and also put patients at pretty high risk of developing complications from long-term steroid therapy.
Thank you, Dr. Tantravahi. And our last question will be, someone asked, am I always considered immunocompromised without a transplant?
So I'm assuming that this is someone with aplastic anemia. Are they always immunocompromised? Well, infections are a major complication of aplastic anemia, both at the time of diagnosis when they're still untreated, and then but majority of the patients with aplastic anemia, even with severely compromised blood cell production, don't really present with life-threatening infections. In fact, majority of the patients come in with sort of non-specific symptoms such as easy bruising, fatigue, and when we do their blood counts, the blood counts are all low. But a small proportion of patients who have particularly very severe aplastic anemia can show up with severe infections like bacterial infections, or even sometimes fungal infections. So in those individuals, treating the aplastic anemia and getting the blood cell production back up is super important to treat the infection. And then in the second situation is sort of long-term risk. The risk of infections in patients with aplastic anemia that are on sort of this immunosuppressive therapy is not super high, But what we tend to see is in some of these patients on this long-term immunosuppressive therapy is higher rates of reactivation of certain viruses like shingles and certain viral infections, but not so commonly a bacterial infection. So there is some risk, but not to the extent that we see in people with, for example, combined immunodeficiency.
Okay, thank you, Dr. Tantravahi, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call the AAMDSIF helpline at 800-747-2820, or submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with our conference sponsors. The next educational sessions will be available in approximately 15 minutes. On behalf of the Aplastic Anemia and MTS International Foundation, thank you for joining us today and for making us your research of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the last 40 years. This concludes the session.